Welcome to the Saving Lives podcast. I'm Eddie Joe. Today we're going to be discussing peripheral vasopressors, and the article that we're going to be using as our reference for this podcast is titled Peripheral Line for Vasopressor Administration, Prospective Multicenter Observational Cohort Study for Survival and Safety. It was published in October of 2025. Links are in the show notes below. As always, hat tip to the authors. Please read these data for yourself, and this is not medical advice. A quick plug for my book, the Vasopressor and Inotrope Handbook. Check out a copy if you haven't already. And to give a little bit more substance to this podcast episode, it turns out that there's a whole chapter on peripheral vasopressors. In the table of contents, if you can see right there. There's a whole chapter on peripheral vasopressors, and this particular study will very likely make it into the 2027 update of that book. So let's talk a little bit more about this study before I keep on rambling on. Peripheral vasopressors have been used for many years now, and the data to support its safety and efficacy is just amounting and amounting. But it turns out that there are a number of institutions that are still kind of dragging their feet on the matter. So that's why I wanted to bring this article to light. See, central lines, which is the traditional way of administering vasopressors to patients, they do have some issues, including mechanical complications, infections, as well as delays to start vasopressors on patients, because believe it or not, there still are institutions where they are not using peripheral vasopressors at all. So this prospective multicenter cohort study asked a practical question: how safe is short-term peripheral vasopressor use, and are the outcomes okay? The design of this trial was a prospective multicenter observational cohort in Ethiopia. So it's in a setting that unfortunately has fewer resources than what we have in the United States for those of us who are in the United States. And this was looked at in both the emergency department as well as the ICU setting across public and private hospitals over there between May and November of 2021. These patients were in shock, and they were receiving IV vasopressors through a peripheral for greater than 1 hour to be enrolled. They did exclude certain patients, for example, those who were in cardiac arrest and also those who had practical workflow issues. They followed up these patients for up to 7 days. So that's a long time. That's more than what we're using in the United States for most cases. And they did have safety checks using a standardized infiltration and extravasation scale. Their pre-specified outcomes were mostly for safety. They were looking for extravasation, ischemia, and tissue compromise. They had some other outcomes, but I don't think that that's relevant to this podcast. Read the paper for yourself if you're interested. So what they did is that they sampled 250 consecutive patients on peripheral vasopressors. These patients, again, were in the emergency department as well as in the ICU. The most common type of shock was septic shock, with 70% of the patients being in septic shock approximately. And then the next was cardiogenic at 22%. So the main question that I ask myself is, where do they actually put these IVs? And we will get there shortly. But the overall extravasation rate was low. It was approximately 1%. And these events seems that they took place after 4 to 5 days of having these peripheral IVs running vasopressors. So typically that's a lot longer than what most institutions are currently running their peripheral vasopressors. For example, at my institution, we recently updated it to allow vasopressors to be run peripherally for greater than 24 hours. In other words, we're allowing up to 48 hours now. That was a very recent change that we had based on these data. So again, notably, no events occurred in the first 4 to 5 days in this cohort. That's a long time. So where did they infuse these peripheral vasopressors? Well, it turns out that the most common location was in the forearm at approximately 40%. The antecubital was next at approximately 30%. And believe it or not, they were using the hand and the wrist, and this was taking place in about 20% of patients. The catheters, they were using mostly 18 and 20 gauge. The ultrasound was used when available, but again, we don't know what the resources were at these institutions to be able to use ultrasound on everybody. Then again, I don't think we use ultrasound on everybody in the United States either. From a medication standpoint, they mostly used 2 different vasopressors. The first and most common was norepinephrine, and then epinephrine was also used. So what are the takeaways from this particular study? Well, it turns out that it does appear to be safe to use peripheral vasopressors over placing a central line in many of our patients. Not that it's better to do it, but I guess it's better for the patient because they don't have to have a line stuck in their neck or in their groin. And it is easier from a time perspective to just place a good peripheral IV instead of having the physician having to drape up and use all the resources from a central line, which again, still does have complications within itself. Now, this study is not without its limitations and without its flaw. First of all, it's an observational study. There's no randomized comparator to using a central venous catheter, for example. There is a possibility of bias with regards to selection bias as well as confounding bias. And then the practice environment shapes the outcomes. If these people are more comfortable at using peripheral IVs, then they're just going to be more comfortable with it than using central lines in patients. This safe window of 4 to 5 days is just an estimate. It's definitely not a guarantee. People could have extravasations beforehand. This is just what was seen in this cluster. And then extravasation management was also not rigidly standardized. They used their own respective local protocols in this. These data also show that you can potentially use epinephrine safely through a peripheral IV, but again, we do not know what the max dose is. And this also does demonstrate that we do not need to use ultrasound for every single line, although I do recommend that every institution has their own protocol to ensure that the IV is being delivered to the vein and not being extravasated right from the jump. So to wrap up this podcast, again, in this 250 patient prospective cohort study, it turned out that running peripheral vasopressors through a peripheral IV, or better said, running vasopressors through a peripheral IV did show very low risk of extravasation, with the events only appearing to happen after 4 to 5 days. Turns out that norepinephrine seemed to be superior with regards to outcomes, and that if we do utilize these protocols, we should primarily focus on placing the IVs in the forearm, 18 or 20 gauge IV, and to make sure that you have protocols in place to ensure that it's being delivered and the patient is not having any extravasation injuries. That being said, we do have to prepare because this isn't perfect. We do have to prepare with respective kits at our respective institutions that have certain tools that you will use for extravasation, whether it be phentolamine or some other agent. Thanks for listening to the Saving Lives podcast. By the way, it's November, and that's why I have a mustache on my face, in case you were curious. It's not a new look or anything like that. It's something I've been doing for the last 13 years now. Make sure to check out the Vasopressor and Inotrope Handbook, and I hope you guys have a great day. Bye.